So I'm going to try and provide you with insights on the pathophysiology, but also on the disease presentation, which I think is really, as already presented just before me, really an extended clinical phenotype. And so just to tell you how I got interested in the condition, was actually a baby presenting at the age of 6 months with very severe RSV infection. And he was born term, so there was no reason, actually, no other reasons to be very ill with it. He was hospitalized in ICU. And at the age of 12 months, he had a Staph aureus lymphadenitis, followed by unexplained lymphoproliferation and refractory pancytopenia. In fact, we tried all the immunosuppressives we had at hand, and finally we ended up transplanting him without knowing the underlying condition. And he's now alive and well without actually further complications. And then his brother presented at the age of 5 months. We were following him very closely from the beginning, and we thought everything was normal. His immunophenotyping was perfect, but then all of a sudden he presented with HHV6-induced erythroblastopenia with a hemoglobin level of 2 grams per deciliter, and then we knew, okay, we are in the same picture as the brother. Then he had recurrent extensive HSV, lymphoproliferation like his brother, and then also CVID like ileitis. So here there were many, inflammatory agglomerates in the bowel, so not like the patient we just heard about. Also interestingly, the boy who I transplanted before had a pineal gland hemorrhage at the time of thrombocytopenia, which is still, even if the levels of thrombocytes are very low, is very rare as a condition. So this is actually when we did the whole exome sequencing on the family, and we found at that time an unknown gene, which was a gene ADA2, and we found a homozygous mutation, the R169Q, in these patients. And very oddly, Mike Hirschfield, who is also the ADA1 and also the ADA2 specialist, was very willingly and also very fast in measuring the ADA2 activity. And then a few weeks after that, he actually told me that the patient I had transplanted had normal plasma ADA2 activity, but the brother, who was ill, had no ADA2 plasma enzyme activity. So the healthy sibling, fortunately, used as a donor, was actually having good levels, and the father and mother had in-between levels. So at this point, he told me at midnight, usually on Thursday, the New England comes out, and voila, there was the paper, the first two back-to-back papers. He said, Isabelle, look up the New England of this week, and here was the initial description of the same condition these boys had. It was ADA2 deficiency, 9 patients from the NIH in this monumental paper. They presented mostly with fever, with livedo, racemosa, and early onset lacunar strokes in the basal ganglia, which really is a very specific phenotype. Some of these patients also had hemorrhagic stroke, but most of the strokes were actually ischemic as the main characteristic. Interestingly, and that's why I hinted to it in the earlier presentations of today, they also had a low serum IgM, which was isolated in the patients here. The other paper was from an Israeli group, from Navon Elkan and colleagues, and their description is actually more one of polyarteritis nodosa, or how we would at least call that from a clinical point of view. And so these patients were mostly from Jewish descent and had mostly a mutation that was the G47R. And some of these also had the R169Q, but most had the G47R. So these were the initial descriptions. And actually, if you read well the supplement of the first paper, I think it contains everything that we now know, but only in a less, let's say, obvious way. And I think now we know that ADA2 deficiency can really, I think, present with any kind of disease you can think of. It can present with inflammation and recurrent fevers only. You can have the strokes, which of course will put you immediately in the right context. But you can also have, quite unexpectedly, hypogammaglobulinemia, viral infections with, for instance, EBV. A French patient was described with EBV-induced aplasia, and then followed by, I think it was a B-cell leukemia. CMV can be very severe. They can have cytopenia, which can be of autoimmune origin or can be really aplastic in origin. And typically, as already evoked, are really the CD8 plus positive T cells that infiltrate in the marrow and that seem to suppress the normal hematopoiesis. Also, quite interestingly, in the most recent years, we've learned that there can be a development of liver disease despite treatment of these patients. So they can have sudden or silently progressive nodular regenerative hyperplasia. And then, of course, you can have the skin phenomena that really fit the diagnosis of vasculitis. And then I want to really highlight also these features of the condition. So one of the, or several of the patients that received transplant in the overview paper actually had indeed lymphoma and leukemia. It's B-cell lymphoma, but also a straightforward Hodgkin lymphoma, some EBV plus, some EBV negative. Also interestingly, so TLGL leukemia, quite a rare leukemia in adults, but also definitely in children even more. Think about ADA2 deficiency as well. It's not a typical feature of a TLGL leukemia, but if you find a TLGL-like picture, it's also one item to think about. It's definitely ADA2 deficiency. HLH that you cannot explain by one of the common or known genes is really important. So there have been cases that look like HLH, maybe not all the features or characteristics that are checked, but still very important to think about it. And then quite interestingly is that some patients have lymphadenopathy and hepatosplenomegaly without any other features. So they can be purely lymphoproliferative. So because of course I came into this field of interest from the immunodeficiency, this was also mostly the gate of entry of the patients in my cohort. So they presented with CVID phenotype, as I said, the lymphoproliferation phenotype. So splenomegaly is also after thinking of, for instance, spherocytosis, I always think secondly about ADA2 deficiency after excluding malignancies, of course. And infections and vaccines can sometimes trigger the onset of disease in childhood. And what is also very interesting, I think, is that some of these patients really present as a lookalike of GATA2 deficiency. I'm still trying to dig out how that really works, but there is definitely a very strong connection. So again, these low IgMs very importantly. And as opposed to the first reports, I think the autoimmunity that we can really prove is rather on the low side. So together with Stu Tanguy, who happened to have also with his clinicians a cohort of patients with ADA2 deficiency, we phenotyped a bit more in depth the immune cells of the patients. And what I think was already well known is that the block at the pro-B cell stage and also their reduced memory B cells and their impaired class switching and actually a peripheral maturation defect with low IgG production also in vitro. They had reduced Tregs. We couldn't test the function yet. And then also interestingly, they have an increased proportion of exhausted CD8 and CD4 T cells. And they produce less granzyme A as opposed to healthy controls. We found that as a signature of type 1 interferon in the patient's periphery, there was an increased expression of CD169. And we thought this could be a nice marker instead of going through the interferon signature, but I'll come back to that later. So definitely a very inflammatory phenotype. And then one of the let's say, entries we are pursuing to better explain the viral infections are the iNKTs and the NK cells that seem to be less mature than in healthy controls. So I think the hematological spectrum of ADA2 deficiency is really, I think, the diagnostic route that at this point is less well explored. Any kind of hematological manifestation is present in more than 30% of patients. I think that's really important. The other way around becomes really difficult because there's very few data. For instance, there's only one cohort of Diamond-Blackfan anemia patients where they only found ADA2 deficiency in 5% of the patients that were sequenced. But for instance, are well known, especially in pediatrics, thrombocytopenia, idiopathic thrombocytopenia, or immune-mediated thrombocytopenia. Several of these patients actually can present ADA2 deficiency. So if you don't look at them and if you don't really measure their immune cells or look a bit further, you can miss this diagnosis, and you will see them later on in life with more, probably more severe manifestations. And also importantly, and as illustrated by the patient from here, from Lille, is it can occur without too many inflammatory symptoms and signs, and it can really be the hematology only manifestation that should hint to the diagnosis. And also don't, like the severe neutropenia is often forgotten, but neutropenia to me is really a very important sentinel or a trigger to think of ADA2 deficiency. Having said that, usually the patients walk in unexpectedly, so I try to screen them all, but then suddenly one adult comes in with severe neutropenia since I don't know how many years with infections, and this is an ADA2 deficiency patient. So it's very difficult to find a really good phenotypical description and filter to say these patients I'm going to sequence and I'm going to test the enzyme activity on. So ADA2 is a complicated gene. It's on 22q11. It's very polymorphic. That's also a problem. So if you run exomes, you can have the problem that you only find, for instance, one mutation or not even a single mutation, whereas the patient can be ADA2 deficient because you can have deletions, you can have entire exons that are actually missing. So you won't pick them up in whole exome sequencing. That's important to know. So if you really think of the diagnosis, you have to do at least the ADA2 enzyme activity with it. There's many, many mutations now, hundreds that are associated with ADA2. They're well reported in fevers. What I think is important is that you look at how the pathogenicity was really attributed to these variants. Yes, you can have the in silico tools, you can have the fact that it's been described before with a patient, but it's still important to really check for the ADA2 protein levels, and much better is actually the enzymatic function of the protein that is still present. And I put a little asterisk there because sometimes I wonder if we're really looking at the right readout to diagnose this condition. So here you have the gene and the different protein units. So you have the dimerization domain, you have the signal peptides, the catalytic domain, the putative receptor binding domain, and the catalytic domain here. So one of the most frequent mutations in our populations is the R169Q, which also was found in the patient here. And you can actually appreciate that it was in the CD, in the catalytic domain. But I mean, these are really throughout the gene. And also, for instance, exon 7, there are several mutations that lead to a total skipping of exon 7. Just to hint to the difficulty of these, of this condition to diagnose it. Importantly, I listed here the most frequent, let's say, variants we encounter in our populations. And interestingly, for instance, here you see the G47R and the G47A. They're very, I mean, they're on the same nucleotide, but still the conditions these patients present with can be totally different. So there is very differential expression of the phenotype despite the same variants that you find. And important, carriers can be symptomatic. So we found in the adult clinic a patient who is R169Q heterozygous, who has carrier level enzyme activity, but has actually hypogammaglobulinemia. And there's one case published like this. So I think we are going into the oligenic inheritance here, or we don't understand ADA2 at all. I think both are possible. So in the early days, we were also looking at how is ADA2 expressed? Is there maybe, let's say, the expression level that correlates with the disease phenotype? And here are a few of our patients here on the right panel. And these are healthy controls, and you can actually see throughout the differential populations, so the monocytes are actually the main producers of ADA2 in the peripheral blood. You can actually see that for these particular mutations where the protein is still expressed intracellularly, there is actually no difference in the intracellular expression. So I think that is already important to think about. And then the paper that was already alluded to in the previous talk by the Harvard group, where they actually show that the later, or let's say the less enzyme activity you have in the plasma, meaning that you have a disruptive mutation that leads to a total loss of expression, or you have, for instance, a splice site or an indel, or a stop, then you have a more severe diagnosis, for instance, purate cell aplasia or bone marrow failure, and your age of onset or age of diagnosis, but here it says age of onset, is also going to be, of course, much younger, which makes sense because these are more disruptive presentations than, let's say, livedo or some chilblains that are mostly probably not even seen by the immunologist or by the pediatrician. So one of the phenotypes, or let's say expression systems, that was used to go into this pathophysiology explanation was an overexpression system in HEK cells. So HEK cells, HEK293 cells, they don't produce or they don't express ADA2. So this was actually the dreamt of model to look for ADA2 enzyme activity in the supernatant. And indeed, if you look at this, it looks really good because vasculitis, you still have some residual ADA2 activity, purate cell aplasia, there is nothing, and bone marrow failure, also nothing. So you remember now this slide here. Is there a genotype-phenotype correlation? There is definitely a hint towards it, and so the more disruptive mutation resulting in a more severe phenotype. So having said that, I put here together a little pro and con on the, oops, my slide is going bizarre, is actually a pro and con on the absent deaminase activity that is driving the ADA2 deficiency phenotype. So I think if you look at this slide here, ADA2 activity percentage of the wild type, if you have a look, these variants are DATA2 associated. And if you look at these, it means that you can have a range from, let's say, 10% or even less residual activity to almost 80%, which is a huge range of residual activity in overexpression to cause the same disease. A very wide range of enzymatic activity. And also, the plasma ADA2 activity varies in carriers with the same genotype. So you probably don't appreciate it from this slide, but you can actually have the same genotype and still have different levels of plasma ADA2 enzyme activity, which makes you wonder, is this really the readout we are looking for? And are we maybe even missing patients by doing this? I'm not sure. It's just, you know, I'm just debating and thinking with you. And even more importantly, ADA2, although it has the name ADA, is a very poor adenosine deaminase for a physiological situation, because we have a much better one, which is ADA1. And in fact, ADA2 was discovered in the spleen as a residual ADA activity in patients with SCID due to ADA1 deficiency. So if you look at, for instance, the enzyme activity indexes of these two, let's say, enzymes, you can see that, for instance, the potency of deaminating adenosine for ADA1 is 70% at this physiological level of adenosine in our blood versus only 2% by ADA2. I think that's really important. And also, if you looked at the Km, so what is actually a constant to say how well it is actually producing or working on the adenosine in the periphery, is much, much better for ADA1 than for ADA2. So it needs micromolars, it needs millimolars here, whereas it needs micromolars for the ADA1, which, I mean, in the opinion of Mike Hirschfield, makes us think that probably the adenosine deaminase is not the foremost and most important activity of ADA2. Well, we will have to discover this. Now I will run with you through a few hypotheses on the pathophysiology, just to set the scene a little bit. So the number one we've already seen. We attribute everything to ADA2 to its adenosine deaminase activity. We have seen all the, you know, all the pros and cons for it. There's the voice that says that enzymatic properties can maybe be outdone by the extracellular environment in times of tumor, stress, or infection. And this would then be the setting where this ADA2 becomes more important and can really have its function in our peripheral blood. Or it could be that ADA2 is a growth factor, and this comes actually from the previous name of the gene, which is cat-I chromosome region 1, CECR1. So it is indeed the case that if you have a duplication or a deletion at this position, that you have a multisyndromal disease, which is called cat-I syndrome. So maybe it has to do with growth factor potential, and maybe that's the reason why there is such a vast diversity of manifestations. I already discussed this with you, so I will not do that again. I just want to highlight also that we have ADA1 bound to the cells, because there is a voice that says, yes, ADA1 works in the cell, ADA2 is secreted. Well, we have a fantastic system that binds CD26, so ADA1 binds CD26, so it can also act actually periphery. And then there's the hypothesis that ADA2 plays a role in cell signaling only and in cell proliferation. There's very few data on that, mostly they're old, and not really at this point really reproduced. And then I think quite importantly and interestingly, ADA2 plays a role in the defense against intracellular pathogens. And I think that is really interesting because the earlier interest in ADA2 comes from instance from studies where they measure ADA2 as a marker of, for instance, mycobacterial tuberculosis pleural effusion. So ADA2 elevated means it's probably TB. Also, if you infect macrophages with MTP, they secrete more ADA2. And the same is actually true if you infect cells with HIV, HTLV1, and interestingly with EBV. So the ADA2 goes up. So there's this other hypothesis that says that ADA2 is a DNase and a sensor of double-stranded DNA. It's true that if you do modeling of the enzyme, that there is probably a groove that could bind nucleotides, but there's a preprint out from the group of Freiburg by Bodo Grimbacher. I think it's been on bioarchives for a few years. I think it would be a very interesting hypothesis. So they would propose that the intracellular ADA2 is actually a DNase or a sensor. But we don't know yet. The only question I think is important is that we at this point don't know the function. Therefore, it's still possible that we miss patients by just measuring enzyme activity. So this is the prevailing hypothesis at this point. Because we don't have ADA2, all the macrophages are skewed towards a pro-inflammatory phenotype. There's a lot of TNF in the environment, inflammation, endothelial damage and disruption, bleeds, etc., etc. So also, of course, very interestingly, if you treat these patients by TNF-alpha inhibitors, mostly they do much better. There's only one big problem. It's the non-vasculitis phenotype. So if you have a patient who has more than just fevers, livedo, and strokes and vasculitis, you're in a problem zone, because you will not treat or be able to cure the patient with TNF inhibitors. And in fact, there's almost nothing you can do at that point until you go to transplant. Also interestingly, there's this paper in Blood from the NIH group that presents that neutrophils play a big role by their advanced netosis in ADA2. But in fact, if I may say so, it's actually been debated because the levels that were found of adenosine in the periphery of the patients that they described has never been confirmed, and actually goes against most of the knowledge we have on peripheral adenosine levels. But still, it's a very interesting hypothesis, and I think neutrophils should definitely not be overlooked in the pathophysiology of this condition. And then to come back to the other big arm of our inflammatory system, the type 1 interferon, and that's actually indeed Alex Belot together with Yannick Crow, who described as one of the first that there is an increased interferon signature in these patients. We also measured that in a few of our patients in the beginning. And we also thought maybe an increased interferon signature is reflecting the disease state, and is actually the higher you are, the worse the phenotype is. That's what we first thought it's only a 6-gene signature. It's not a nanostring full thing, but still. We did it now with our larger cohort, still less than 20, but still. And what we created was actually based on the paper that was also quoted, the paper by Filière et al. They actually propose a start of a severity score for patients with ADA2 deficiency. We submitted it recently as a paper because I think it would be very useful to score these patients every time you see them and see how they evolve. And what we did was actually try to find a correlation by Spearman testing between our inflammatory score, the CRP of the patient, and the interferon at that point. And basically, they're very poor. The correlations are very poor, and we can actually not find a correlation with any of the easy markers with the disease state of the patients. And so this takes into account all the manifestations the patients can have, and including also the hematological counts, for instance, neutrophils, anemia, and also lymphocyte levels and thrombocyte levels. So basically, it's very difficult, and I think we would need to try and repeat this in a very big cohort and try to find a better way of thinking of type 1 interferon. Having said that, the type 1 interferon pathway is one of the pathways that is most pronouncedly upregulated if you look at transcriptomics, be it of whole blood or PBMCs. Let's say the type 1 interferon, type 2 are both on top. However, treating these patients with, for instance, the JAK inhibitors, I would be less, let's say, happy to do that on a big scale without a good supported study behind it, because I think we could have a lot of complications in terms of viruses and in terms of even more profound cytopenia. But yeah, we don't know at this point. So I'm now coming to a more interesting, maybe even matter, is that for a long time, the bigger player that we are losing out of sight is the endothelium. So strokes, the bone marrow, even with a very important endothelial contribution, egressing all the support that is being delivered to the marrow. What is the role of endothelium? And in fact, the first papers really were, you know, very clear on that. There is no endothelial expression. This was tested, I think, in a few cell lines, including HUVEX. So there was no STAT2 mRNA, no STAT2 protein expression. Yeah, in fact, there was then a follow-up paper published in Science Advances, which has been very much debated by several of the people working in ADA2 deficiency. And this paper actually proposes a very complex hypothesis that is well underbuilt with experimental data. And they show that ADA2 is a negative regulator of IRF3 in the HUVEX, and that if you don't have ADA2, you have spontaneous interferon beta production by the endothelium. Okay, in HUVEX, but still, it's very interesting. And also, if you look at here where they actually try to infect the cells with CMV, you can actually see that if you treat the cells with silencing ADA2, that you have then actually more induction of interferon beta than in the control. Also, if you look in transwell setting, you can see that ADA2, at least that's what they measured, ADA2 is a majority of secreted ADA in the HUVEX, acting then on the monocyte cell line in co-culture and leading there to more interferon beta again. Very interesting hypothesis. But it goes further. Then they attribute the most important role to deoxyinosine. And they show, this is very complex, but I think it's undebatable that they showed all the data. They show then that this inhibits the methylation in the HUVEX, and that this hypomethylation leads to overexpression of ERV transcripts and therefore interferon beta production. So they attribute the role to endogenous retroviral elements. So much debate. I think nobody wanted to believe. There was even a commentary saying that it's not true and they don't produce ADA2. By the way, it goes in a way against the fact that stem cell transplantation is very successful also in preventing strokes. So I think I was very interested in endothelium from the start. And so we did a few experiments. I must say it's very, very difficult to try even to do a Western blot that is reliable for ADA2 because it's a very tricky protein. But what we showed both in HUVEX and in other endothelial cell lines that are derived from organs that are interesting, for instance, brain microvascular cells, or for instance, the bone marrow derived cells, we find variable levels of mRNA. And we could also find, not in the cell, but secreted in the supernate, that we could find actually ADA2. And interestingly, the most prominent production came from the primary lung endothelial cells. That was actually, okay, not comparable to the U937 cell line, but still quite very much expressed. So I think, what is the role of this ADA2? I have no clue at this point, definitely not. We are now doing blood outgrowth endothelial cell lines from patients versus controls to really look then in co-culture what can this be and what can this mean to the patient. And I think one of my hypotheses is that maybe if you are in the setting that you've transplanted a patient, and that you are in the setting where the monocytes from the donor need to come in and need to take over the production of ADA2 in a healthy way, that maybe this time frame is the time where you can have a role for the endothelium and for the tissue-resident macrophages, for instance. Or maybe also in the setting where you have a secluded organ that is very endothelium-rich, and where you don't have the monocytes yet to make sure that everything is cured. I don't know, but at the least we can say is that there is ADA2 expression, be it at a low level. The next item in my debate is actually the treatment, and I think most of us are clinicians, if not all. So anti-TNF therapy is definitely the number one to start with. And it's very efficient in preventing new strokes. There's been a few papers of breakthrough strokes and breakthrough vasculitis, but very limited, and very efficient also in the treatment of any kind of other vasculitis phenomena. However, there is no proven and maintained efficacy, as far as I know, for bone marrow failure or for the dysregulatory syndromes. Also not for hypogamma, because it has been published that by giving anti-TNF you can reverse the bone marrow development of the stop in the B-cell development in the bone marrow. In my experience, it has never happened. So I don't believe this. And I think you always have to be aware the vasculitis may not be that well controlled. So you really have to look carefully at the patients, maybe escalate the treatment. Some of them do have complaints and do have still vasculitis problems, and so maybe therefore it's also still a population at risk to have strokes and other complications. And this was already mentioned. I think stem cell transplants can really be life-saving to these patients because, yeah, at the end, as we saw in the patient, they end up with no more cells left, and then it becomes probably very difficult to do anything. Also, if you think of the future gene therapy, I don't know, then you will need marrow to put those viruses and those vectors in. So how long do you wait to do anything? So I'm a convinced transplanter of these patients, with the caveat that indeed you can have this problem of the second transplant that you need, and some autoimmunity also. This was an unfortunate patient who died actually a little bit after engraftment with parainfluenza virus infection, was a younger child. But the rest of the patients, I think by and large, despite the difficult trajectory, are doing fine. And I think that's also important. Oops. We already discussed this, and I just wanted to highlight there. We saw the CD8 clones in the bone marrow, and that is why it's really we believe, very important to get rid of the T cells in the bone marrow. Because we believe that if you keep that group or cluster of recipient T cells in the marrow, you will not succeed in getting the graft accepted. So we believe, there's no big data, it's only 30 patients, but that's what we believe. To give the incoming cells some survival benefits. And by the way, also some of these graft failures were also really with very low stem cell dose, so I have to be a little bit careful with the interpretation. So I think I will have convinced you that ADA2 deficiency is a very complex inborn error of I don't know what, metabolism, immunity, I don't know what. I think it can do anything. Has a central role for the monocytes because they're the main producers. Neutrophils also produce, but I also think endothelium has a role. We'll just have to figure out what it does. I don't know if ADA activity is really central to the diagnosis. Maybe in 10 years from now, I think I'm stupid saying this, but I don't know. I'm not convinced yet. And there's many unanswered questions which I didn't touch really upon. It's the incomplete penetrance, the differential expression of the phenotype. We don't know the triggers. Sometimes it's like, as you say, you start the treatment, doesn't work, and then you get fevers and inflammation. There's a lot we still don't understand. The type 1 and type 2 interference signature, and still very, very many infections in several of these patients, very difficult to understand. But anyway, stem cell transplant suggests that hematopoietic cells are the central drivers of the disease, and I think that is also still a cure that we can offer and that we should not be afraid to offer for these patients, especially not for the children. So my thank you slide to my funders, definitely to all the people I've discussed this difficult disease with who sent me patients, and I think also a big thank you to the patients and their families, because yeah, it's not always straightforward what we have to do for them. And this is my lab, and they do most of the work, and I think they all hate ADA2. That's what I think. Thank you.